Good morning, everyone. I'm Chad Ray, the Vice Chair for Education for the department, and I wanted to, make sure everyone can hear me. I don't know if I'll get any feedback from you or not. Hear me, Victoria? Okay, good.
Yeah.
But it's my honor today to, have this guest speaker for Grand Rounds, someone who has given us Grand Rounds in the past, and someone who is very important to all of us right now as we go through this pandemic. I'll first just say that Dr. Vasquez is the professor of medicine here, and he's the chief of the division of infectious disease. He came to Augusta University from Wayne State University. I think he was at Wayne State when he gave us the Grand Rounds previously. Is that right? And most of us have seen him pretty much routinely, maybe not every day, but perhaps most days. I saw him on TV one day around 6 o'clock, and then I went for a walk in my neighborhood and I saw him picking up some food about 6:30. So I thought to myself, I see him like maybe he, somebody who I'm going to see like every day for sure. Everyone who's in my circle certainly knows that I've become a student of infectious disease, and when they talk about the things that are really global killers, two of those things have to do are right in his wheelhouse. One of which is a global pandemic, which we're in right now, and the other is emergence of antimicrobial resistant organisms. And today, Dr. Vasquez is going to talk to us about antimicrobial stewardship. So let's all welcome Dr. Vasquez. Thank you, sir.
Just a hand clapping. Okay, good morning, everyone. It's certainly a pleasure to be back. It's been a couple of years. And so what I'd like to go through today is not going to talk on COVID. We've had enough COVID for now. We're going to talk on our antimicrobial stewardship that we have here, and actually some of the newer antimicrobial agents that we have available, plus our antimicrobial stewardship program that we have available. So without further ado then, let's see if we... All right, so the couple of objectives that we have. Number one is to define what our antimicrobial stewardship program is, specifically here at MCG, the concepts of the program and the 4 goals that we have as far as antimicrobial stewardship are concerned. And then we'll give you a couple of examples of some of the newer antimicrobial agents that we have. So this is the statement from our Infectious Disease Society, SHEA, which is the Society for Epidemiology, is a coordinated effort to improve and measure the appropriate use of antimicrobial agents by promoting the selection of the optimal antimicrobial drug regimen, including dosing, duration of therapy, and route of administration. And our antimicrobial stewardship program here actually includes a combination of an infectious disease physician, a PA that we're just recently hiring, and then 2 antimicrobial stewardship pharmacists that'll help you. And the key to the principles of antimicrobial stewardship are, one is to optimize your antibiotic. Choice of antimicrobial agents become very important. The dosing is another one that becomes very important. The route of administration, and certainly the duration. And just the key to the duration is nowadays, the shorter, the better. The fewer. Okay, so as I mentioned, as far as the stewardship is concerned, so I'm not going to go through the definition again. I think everybody heard it. So we're on the optimization of antibiotics, meaning the choice of antimicrobial agents, and narrower the better. Always a key. The dosing has to be sufficient enough to get the antibiotic to penetrate wherever it's going. The route of administration. So if we can do oral antibiotics, we try to do oral antibiotics. Duration of therapy, again, the key to duration is the shorter, the better in all of these. And the reason for that, obviously, is trying to limit collateral damage of antimicrobial use. Besides the adverse events and toxicity, the development of resistance, which I'm going to discuss a little bit later on, and obviously, as everybody's well aware of, C. difficile infection, which we are having a problem here in this institution with the number of C. diff infections that we have. So one of the keys to probably the most important subject or topic as far as limiting C. diff infections is the role of antimicrobial utilization, broad spectrum versus narrow spectrum, and shorter duration. Much, much better. So the components of stewardship, de-escalation of therapy, and whenever you have an ID consultation, you'll notice that we try always to narrow it down. If we have a gram-positive, then we only need a gram-positive coverage, not gram-negative. Dose optimization, and that comes into play depending on the weight of the individuals and the site of the infection. IV to PO conversions, the PO is always a lot easier to send the patient out, and certainly a lot cheaper than the parenteral formulation where you have to have an IV, PICC lines, and with that comes the complications of a phlebitis, thrombophlebitis, and bacteremia. Recognizing we do have guidelines, and I'm going to show you some of the guidelines and pathways pertaining to you guys, and then education, I think, is the key and component. By us coming in and telling you to change the antibiotic because they're not on the right one does not help. Educating you and letting you know why this antibiotic is more appropriate than the other antibiotic, I think is the key, and that's something you should expect from the ID team and from especially from the antimicrobial stewardship. So I have a pop quiz here. This is a patient who was admitted 2 days ago with pyelonephritis. He was put on vancomycin and pip/tazo or Zosyn in the emergency room from the community. So this is a young lady who comes in. Why were they put on vancomycin and Zosyn? I don't really know. It appears to me after being in Augusta for a couple of years, there must be a deficiency of vancomycin because everybody gets vancomycin or vancomycin from the emergency room. At any rate, so the blood culture pops back as E. coli within 24 hours, and the urine culture 48 hours later comes back as E. coli as well, with these same susceptibilities. So what we're looking at susceptibility-wise is you can see that this organism is very sensitive to all the different agents that are available. So obviously what we'd like to do is to de-escalate and to use an oral agent if possible. You don't need to use an IV after the patient, especially if it's pyelonephritis, after the patient is stabilized. So the possibility of a narrower spectrum, such as ampicillin, is certainly something that can be used, easy to use in the hospital, or even trimethoprim sulfate methoxysol. If the patient doesn't have nausea, vomiting, and is able to tolerate oral therapy, that would be the recommendation. So amazingly enough, when we called in half the time through the stewardship service, the patients are maintained on the same antibiotic because one is the physician has realized it, and number two, the reasoning is that they're doing well on these, why change it? So the key to this is de-escalation, number one, narrowing the spectrum, and number two, going from a IV to PO regimen so you can get the patient out. Not everybody needs ciprofloxacin if they have a urinary tract infection. That actually has gotten us into trouble over the past couple of years. So example of this is how to de-escalate, number one, and number two, how to switch from IV to PO, depending on your susceptibilities that you have in your patients. So you can theoretically send this person out on an ampicillin or on trimethoprim sulfate methoxysol. So why is stewardship necessary? This is from our Clinical Infectious Disease Journal back 2 years ago, where we've seen this rapid decline of new antibiotics and drug discovery. Where back in 83 and 87, a 4-year span, we actually had 16 new antimicrobial agents. From 2008 to 2012, we've had 2, and from 2012 to 2020, we actually have had 4. So we're having issues, we're having problems with newer antimicrobial agents. Why do we need new ones? Because a lot of our patients are developing multi-drug resistant organisms, MDROs, specifically within the gram-negative realm. So one of the reasons, again, is de-escalation. Escalating rates of multi-drug resistant antimicrobials account for about 1/3 of the hospital pharmacy budget. So you can imagine the number that we see there. 50% of antimicrobial use, believe it or not, in the hospital is inappropriate. A lot of times when patients get admitted to the hospital, they get admitted on a broad spectrum antibiotic from the ED, which is fine because they're triaging the patient. But it's important for you to realize that once they hit the floor and you have an organism and you have in vitro susceptibilities, again, we try to de-escalate, whether it's narrowing the spectrum or switching from IV to PO. So this broad spectrum has led to an increase in resistant pathogens, and I'm going to show you actually your susceptibilities to your flora in just a second. This is just to give you an example of a program that's called Bad Bugs and No Drugs, which we've been pushing actually through Congress, showing the amount of MRSA that has increased. So back in 1980, there was very little MRSA in the country. This is the country. We now look at what we see in the community, and we see that MRSA is up to about 60%. So less MSSA and a lot more MRSA. The other one that you may see is enterococcus, which is not uncommon in the urinary tract. And we can see that back in 1986, 87, 88, there was no vancomycin-resistant enterococcus. And you can see this is actually cuts off in 2004. This had continued to increase. We're at about 25% rate of vancomycin-resistant enterococcus. Probably more important than that is actually the fluoroquinolone-resistant pathogen, specifically E. coli, which was non-existent back in 1990, and you can see where it's at. It's up to 30%, and I'll show you where it's at here in this institution. We're having problems actually with urology and urologic service because they love to use ciprofloxacin as a prophylactic for a lot of their procedures. So when you use cipro as prophylaxis and you have a 30% rate of resistance, patients don't do well. Actually, it's not uncommon for them to come in within 24 hours in septic shock with an E. coli that's resistant to fluoroquinolones. The other reason it's needed, obviously, is the resistance negatively impacts morbidity, mortality. Increased morbidity, mortality increases about 30%. Length of stay increases a significant amount, whether it's a gram-positive pathogen or a gram-negative. Bloodstream infections, surgical site infections caused by MRSA, and this is on the lower end, somewhere between $9,000 and $13,000 just from this type of infection. Bloodstream infections caused by vancomycin-resistant enterococcus has been shown to increase length of stay and decrease survival. So this becomes very important, recognizing that last year, which was a decent year, we had about 1 to 2 MRSA bloodstream infections in the hospital, which is about $750,000, okay, is what it cost us here at this institution. One of the reasons we're trying to eliminate the Lyme-related bloodstream infections is because the cost, and obviously number 2 is, well, number 1 is morbidity, mortality. Number 2, obviously, is the cost. The same thing holds true with vancomycin-resistant enterococcus. So in this institution, where do we see most of the vancomycin-resistant enterococcus? It's actually in HEMONC. So HEMONC has the highest rates of vancomycin-resistant. We actually track per floor, and HEMONC has the highest rates of vancomycin-resistant enterococci in the MCG. So the core strategies, what we look at it is prospective audit and feedback. Number 1 is we take a look at, and we actually have a program called Theradoc. The Theradoc program, basically what it does is allows us to look at all the infections in the hospital and the antibiotics that the patients are on, making sure that we have a match between the bug and the drug. And we actually do that on a daily basis, sometimes twice a day. Because it's amazing, about a third of patients that are on antibiotics are on the inappropriate antibiotic. Up to 50% of patients can actually be switched and made a lot more antimicrobial stewardship friendly, if you will, in that setting. The other thing that we've done, and I'm sure most of you are aware, is we have formulary restrictions. There are some antibiotics that are require an ID consultation or an ID approval. There's some that actually require pre-authorization, and there's some that actually require some kind of criteria to be utilized throughout the hospital, just in case you guys are aware. So these are the 2 things. And feedback comes into play when the ID team or the stewardship team comes back to discuss the patient with you, asking you to perhaps change an antibiotic or modify an antibiotic so we can stay within our criteria. So these prospective audits that occur on a daily basis through this Theradoc system. And that helps us with the direct interaction, the feedback that we have. And then what that does is actually reduces the inappropriate use of antimicrobials. And not only reduces, but I would say a good 50% of the time, we are able to switch from IV to BO. And about a third of the time, we're actually able to stop the antibiotic. So patients don't have to go home on the antibiotic, don't have to get a PICC line or midline or a catheter to be sent home on antibiotics. So we're pretty effective in reducing the entire total utilization of antimicrobial therapy. So the formulary restrictions, as I mentioned before, there's restrictions where antibiotics are on the formulary. There's pre-authorization where ID requires. Sometimes it's a consultation, sometimes it's just a phone call to say, I want to switch from this to that antibiotic, and that leads to a stewardship consultation. And that can, again, lead to an immediate significant reduction in antimicrobial use and a decrease in broad spectrum to narrow spectrum antibiotics. So the primary goals that we have here, number one is obviously improving patient outcome, getting the patient out of the hospital with minimum morbidity and minimum mortality, decreasing the length of stay. All of that decreases and improves patient safety. Patient safety, reduce generation of multi-drug resistance or resistant organisms, and all of this at the end eventually reduces cost within the hospital system. So multiple goals that we have, and it really all boils down to matching the appropriate drug with the bug that your patient has by cultures and by susceptibilities, which are the two things that we look at, in addition to the type of infection that the patient has. So this is the antibiogram available, and these are the gram-positive cocci. There's no big deal in gram-positive cocci. The top part is the MSSA, where we see that MSSA are all susceptible, and the drug of choice nowadays for methicillin susceptible staph aureus is cefazolin, number one. And levofloxacin, which is used very frequently, should not be used because you can see that the susceptibility is only 67%. For MRSA, what I do want to point out with MRSA is the fact that on occasion we are able to use clindamycin for patients that have a skin soft tissue infection, not for bloodstream infections. And probably the other drugs that's used very frequently is a tetracycline, meaning doxycycline or minocycline in that setting. A lot of individuals like to use trimsulfa. You have to be careful with trimsulfa because you can see that about 20% of the MRSA are actually intrinsically resistant to trimethoprim sulfamethoxazole. So if you're de-escalating and want to send the patient home on an oral antibiotic, your best choice, my choice, is actually one of the tetracyclines. Doxycycline is the one that you can use. Clindamycin is the other alternative that you can use, or a first-generation if it's MSSA, then a first-generation cephalosporin is your drug of choice for the gram-positive. So this is the easy version. Gram-negative bacteria, these are the most common ones that are seen. E. coli is number one, 40 isolates out of the total, followed by Klebsiella pneumonia, Proteus mirabilis, and then just a handful of other organisms. The one area that I do want to point out for E. coli is ciprofloxacin, where on the 7th floor, actually, it's not bad comparison to the rest of the hospital, but it's about an 8% resistance rate. So you're not guaranteed with ciprofloxacin coverage. Gentamicin, if you decide to use gentamicin for gram-negatives, you can see this has actually started to drop. It's at 90% and continues to drop. It has continued to drop for a period of time in that setting. So most of the time when we're looking at an E. coli, we're probably looking at least at a third generation cephalosporin. There is no need to use pib-tazobactam. There is no need to use meropenem in that setting because these are anti-pseudomonals, and we really like to restrict. So one of the drugs of choice, if you have a gram-negative that's not Enterobacter, would actually be ceftriaxone, where we can see 100% susceptibility with E. coli, Klebsiella, Proteus, and even the one Serratia marcescens. You do have to be careful with levofloxacin, with levofloxacin as well, if you decide to use levofloxacin for E. coli, because that's down at 92% as well, so you do need to know. Trimsulfa, which is another one that's frequently used for urinary tract infections. If you come over here to the right-hand side, you can see that 20% of the E. coli are resistant to trimethoprim sulfamethoxazole. So beware. And ampicillin is not a drug that you should be using for E. coli. 50% of the E. coli are resistant to ampicillin. Thus the importance of having this antibiogram, which, by the way, you can actually you can pull up under the stewardship and under the pharmacy website, that setting. Upcoming changes that we have, there are going to be a couple of ID-restricted antibiotic policy updates that we're working on. Appropriate antimicrobial dosing that just recently went through. Committee dosing in obesity becomes important. The treatment for C. difficile has actually changed in the past year and a half. I'm going to show you what that is in just a second. Febrile neutropenia, and starting from next month, patients that have a Staph aureus bacteremia, a candidemia, or a multi-drug resistant bacteremia are actually going to require an infectious disease stewardship consultation. The reason for that is because we have found out that these are the 3 types of infections that patients are frequently discharged on inappropriate antibiotics, and they actually eventually come back, and a percentage of these come back with staphylococcal endocarditis, specifically if they have Staph aureus bacteremia. So in the future, we're going to have a mandatory consultation for anybody that has candidemia, invasive candidiasis, or any multi-drug resistant. So what the definition of an MDRO is: resistant to 3 different families of antibiotics. And I'm going to show you that in just a second. So catheter-related bloodstream infections, we have had a process in place for about 4 years now, where if you're putting in a PICC line or a midline catheter for antibiotic use alone, that actually requires a stewardship approval or a stewardship consultation. That's nothing new that we have. We're just going to get a little stricter on that because there are still patients that are being sent out like that. A couple of changes: we've actually removed levofloxacin from formulary last year. Doripenem is non-formulary. Imipenem, which was the original carbapenem, was also removed, as was conventional amphotericin B. We no longer use conventional ampho. We actually use liposomal amphotericin B, and we removed another antifungal called anidulafungin. Drugs that have been added over the past couple of years: ceftaroline, which is a 5th-generation cephalosporin that has activity against MSSA and MRSA. Moxifloxacin is being used instead of levo. Ertapenem, which I'm sure a lot of you may be familiar with. And we've actually added 2 new antifungals for broad-spectrum resistant Candida species. Posaconazole and isavuconazole are 2 of the newer generation azoles that we have available. The reason for that is because a lot of our candidas that we're seeing in the institution are Candida glabrata. Candida glabrata is frequently intrinsically resistant to fluconazole. So if you have a patient with Candida glabrata, beware that about 40% of the Candida glabratas are resistant to what we normally use, which is fluconazole. The last antibiotic that we've added to formulary is ceftazidime or avibactam. The trade name is Avicaz. And this is really only used for multi-drug resistant organisms or carbapenemase resistant Enterobacteriaceae. And I'm going to show you that in just a second. That's a big component of our multi-drug resistant organisms that we see. This group should not see a lot of carbapenemase resistant Enterobacteriaceae, although we do have it in the community. Most of the CREs, as they're called, are actually found in patients that have been in the hospital for a prolonged period of time, number 1, 2, or are coming in from long-term care facilities, nursing homes, and they frequently have had multiple admissions for numerous types of infections. Just a little spectrum on the fluoroquinolones, because we no longer have levo. We do have ciprofloxacin, which we don't use as much anymore as we used to in the past. Moxifloxacin, the difference between levofloxacin and moxifloxacin are twofold. One is levofloxacin is excreted via the kidneys, so you do need to know what the renal function is to give the appropriate dose for levofloxacin. And moxifloxacin, which is actually primarily metabolized by the liver. No minimal excretion in the urinary tract, so not a drug that you would be using for a urinary tract infection. The other difference between levo, cipro, and moxi, if you look at the anaerobic organism, that actually has good activity against anaerobes. So it's actually a drug that could be used theoretically in patients that are penallergic and have an intra-abdominal infection, because it covers the gram-positives, covers gram-negatives, not Pseudomonas, and it covers anaerobes, all the anaerobes, including B. fries. Matter of fact, it's one of the drugs that I use for a outpatient diverticulitis, for instance, when I want some gram-negative and some anaerobic coverage. And it's a drug that can be used to send the patient home on, so you don't have to use the combination, say, of Cipro and Flagyl or Levo and Flagyl. Those do not have anaerobic activity. And then you can see there the other activity. Cipro used to have good activity against gram-positives. It now has very poor activity against gram-positive. Why? Because it's been around a long time. And it's been used for many, many different types of infections and many different types of diseases. See, there's just a couple of the FDA-approved indications that we have for Cipro. Cipro is no longer approved for pneumonia, for community-acquired pneumonia, for strep and Haemophilus. Levofloxacin, moxifloxacin are now what are called the respiratory quinolones in that setting. Cipro and Levo for urinary tract and pyelo. Again, the reason Moxie is not there is because of poor urinary excretion. Bone and joint, we actually can use any of those, but it is FDA approved for that. Skin, soft tissue infections, levofloxacin, moxifloxacin, and then you can see prostatitis there. Febrile neutropenia, because there is some Pseudomonas involved, that's also a possibility as well. So you can see the FDA approved indications for quinolone. So what about ertapenem? This has actually gained a lot of traction over the past couple of years because we have started to see a lot of gram-negatives resistant that have ESBLs. So same coverage as meropenem, meaning broad spectrum with the gram-positive, gram-negative, and anaerobic spectrum. But if you look at the middle, the APE, it does not cover Acinetobacter, Pseudomonas, or Enterococcus. So those are the keys. So the reason we like to de-escalate the ertapenem over meropenem, which is the one we have here available, is to try to salvage some of the anti-pseudomonal activity that we have with meropenem. So that's the big difference, and that's one of the reasons that we actually use. The other reason is that it's a once-a-day drug. So if you ever need to send a patient home, it's a lot easier to get somebody to take a drug once a day, 30-minute infusion, and you're done, versus the meropenem that can be 2 to 3 times a day, depending on the renal function. So again, ertapenem, the great part about it is the Pseudomonas salvaging therapy, if you will. We don't have to compromise the Pseudomonas activity of meropenem. So some of the ID-restricted antibiotics that we have available, we actually have a coding system, and we have what's called a criteria-monitored antimicrobial policy. And what that means essentially is if the patient meets certain criteria, you are allowed to prescribe the antibiotic. You don't need an ID consultation. So again, if you have, and patients meet those criteria. So just to give you an idea, not that we use a lot of Astreonam, but on occasion for those patients that are panallergic and have a documented gram-negative infection specifically with Pseudomonas or multi-drug resistant organisms, those are criteria monitored that you can actually use. So a Pseudomonas infection where you know you have susceptibility to Astreonam. Cefepime is the other one that is criteria monitored, and that's used where you think there may be resistant gram-negative organisms, specifically, especially looking at Pseudomonas aeruginosa. Empiric therapy is allowed for 24 to 48 hours, up to 72 hours post-admission. After that, then the patient needs to be reevaluated to see if either therapy can be discontinued, number one, or if therapy can be modified and we can stop the anti-pseudomonal coverage of cefepime. And this is probably the one that's used the most now in this hospital when patients develop a nosocomial infection, whether it's a urinary tract infection or a respiratory tract infection like an aspiration pneumonia or ventilator associated. We've actually all gone to cefepime instead of the old standard of piperacillin, tazobactam. Ceftaroline is the other drug that's actually been used much more frequently. This is actually, and these are the criteria for community-acquired polymicrobial skin structure infection with an open wound, for instance, a diabetic foot. Where you think MRSA is suspected or documented, but the patient is intolerant or allergic to vancomycin. So the definition of intolerant is a patient, for instance, who's developing or has developed acute kidney injury or has some kidney damage because maybe they were on vancomycin before, or they were in shock and they developed acute kidney injury in the hospital. So if your patient starts to develop an increase in serum creatinine, and this is one of the possibilities if you're trying to treat specifically MRSA. And then number 3, suspected or documented MRSA, skin and scuff tissue infection in patients with renal insufficiency or worsening renal function, and IV is necessary. So avoiding vancomycin and using ceftaroline, it's as good, if not a little bit better, in clinical studies for MRSA, skin soft tissue infection. We actually use it now for bacteremia as well, and even endocarditis in that setting. Suffixing second line for Neisseria gonorrhea. Ceftazidime we only use in one setting, and that's in patients that have cystic fibrosis. So we are trying to reserve it for that. That is an older 3rd generation cephalosporin that we've had, but it's only used for cystic fibrosis patients unless there's another reason. Tenofovir for viral infections needs required ID approval for all indications. This is ciprofloxacin. As you can see, there's a multitude of criteria where it can be used for, whether it's a documented gram-negative infection resistant to all beta-lactam. So that would mean patients resist that organism is the gram-negative, whether it's a Pseudomonas or a Serratia or an Acinetobacter is resistant to Pip, Tazobactam or Zosyn or cefepime. So this would be another option. Infections in cystic fibrosis, we use it, and you can see there's a whole host of criteria monitored where, again, if the patient fits these criteria, you actually don't need an ID consultation because of these monitored criteria. Daptomycin for gram-positive infections, specifically MRSA and VRE, requires ID approval. And the reason for that is the cost. It's about $1,000 a day for daptomycin. Very effective, and because it's dosed on a kilogram, milligrams per kilogram. In the patient, in the larger patient, it can be very, very expensive, and we have other options that we can use. Ertapenem, as I mentioned before, is one of the preferred agents for documented or suspected infections due to ESBL gram-negatives. So specifically the bacteria, as I mentioned before, whether it's E. coli, Klebsiella, Serratia, or Enterobacter, or the treatment of community-acquired intra-abdominal infections or skin structure known or suspected to be polymicrobial. Again, I'll reiterate that ertapenem does not cover Pseudomonas, Acinetobacter, and does not have great enterococcal coverage. Foscarnet is for CMV. Itraconazole requires approval. That's really only used for one situation, and that's usually for histoplasmosis in patients. And we have significant histo here, but it's generally not an issue. Linezolid or Zyvox, it comes in IV and a PO formulation. This is primarily to treat a vanco-resistant Enterococcus faecium or vanco-resistant Enterococcus faecalis that can occur. It should not be used for bacteremia, but it is one of the drugs that we use frequently in patients, for instance, that have MRSA pneumonia that are not responding to vancomycin or not responding to the normal antibiotics that we use. Other than that, it's actually required, ID is required for all other indications. If at all possible, oral therapy can be used. It has the same bioavailability, a little bit cheaper, but not a lot cheaper than the parenteral formulation, even though this has now gone generic. It's still a relatively expensive antibiotic. Meropenem, everybody's aware, documented for cefepime-resistant, Zosyn-resistant gram-negative infections. Micafungin is our primary drug that we use for patients with candidemia or invasive candidiasis. And the reason for that is, as I mentioned before, our most common candida species here is Candida glabrata. The old term was Torlopsis glabrata, which is 40% of these are resistant to fluconazole. So if you suspect an invasive candidiasis, if you suspect a candidemia, please initiate micafungin first. Once you have the species identified, then you can de-escalate depending on what the organism is. If it's a Candida albicans, then by all means, you can de-escalate the fluconazole. But if you have a patient that's sick and you think there's candidemia or invasive candidiasis or intra-abdominal candidiasis, then please initiate micafungin, which is our echinocandin. Pentamidine is used here for pneumocystis carinii pneumonia. It's not our #1 drug, but it can be used. Pip/Tazo was our main antibiotic for healthcare-associated infections It no longer is our main antibiotic, and the reason for that is over the past couple of years, we have seen about a 30% rate of acute kidney injury when the combination of vancomycin was used for more than 72 hours. That's the reason that we have switched for nosocomial infections where we initiate vanco and cefepime. But you can see here, again, this is for broad spectrum, specifically if we need to include Pseudomonas aeruginosa, but use it carefully in your patients if you are also using vancomycin at the same time. Posaconazole is one of the newer azoles. This is used primarily for prophylaxis in patients that have AML, myelodysplastic syndrome, or that are undergoing allogeneic bone marrow transplant. In addition to that, the other indication is for mucormycosis. So this is one of the initial drugs that can be used IV or orally for a patient that has a mucormycosis, wherever that mucormycosis is, which you probably won't run into very much in this type of setting. Valganciclovir is for CMV, retinitis, or disseminated CMV infection. Oral vancomycin, again, used for C. difficile infections. That's it, because it has no absorption. Voriconazole is an azole that's been around for a while, the drug of choice for invasive aspergillosis and many other mold infections. It also is used for prophylaxis in patients that are getting transplanted or AML or myelodysplastic syndromes in hematology and oncology. There is an IV preparation and there's an oral preparation. So we on occasion will use this as a step down after we're done with the echinocandins if we know that it's susceptible to voriconazole. But voriconazole is really the main drug of choice for invasive aspergillosis in that setting. So just a couple of slides on C. diff infection, because it is really one of the biggest problems that we have in this institution. Mortality rate with C. diff from mild to moderate to severe is anywhere between 6 and 30%. The assay that we have available here is the PCR, which is the assay of choice for diagnosing C. difficile infection. The downside to the assay is the fact that it can actually pick up C. diff for many weeks after the patient has had C. difficile. So number one is that a C. diff assay is not going to be done in patients that do not have diarrhea, meaning by definition, at least 3 stools in 24 hours, and the stool has to basically form the shape of the cup that it's being put into. The reason for that is because we're actually getting a lot of patients, and about 10% of the population is colonized with C. diff, completely asymptomatic in that setting. So one of the reasons that we're getting a higher C. diff is because there was actually stool that was being sent for patients, for instance, that were on medications to have a bowel movement, whichever one that was, Colace or any of those laxatives, stool softeners, and they were coming up positive for C. diff, even though they were afebrile and had no other manifestations. The C. diff toxin is still diagnostic. It is not available here, but what it does indicate is active development of toxin activity. It's a bit more specific, and on occasion, sigmoidoscopy or colonoscopy, you can see the pseudomembrane, but the diagnosis of choice is the PCR assay that we have here available. So the treatment has changed. So it used to be metronidazole, number 1, 2, and 3. Now, initial treatment for C. diff is either fidaxomicin at 200 milligrams twice a day for 10 days, or vancomycin 125 milligrams 4 times a day for 10 days. And the reason for that is a large study that was published a couple of years ago showing that patients that got either fidaxomicin or vancomycin had much lower rates of recurrence and fewer hospitalizations after they were treated for that. Only if you cannot use fidaxomicin or vanco, and we do have both on formulary here, should you be using metronidazole at the 500 milligram 3 times a day for 10 days if it's a mild infection. If the patients have a recurrence, and they do occur in up to 30% of patients, the second recurrence the first recurrence, should be treated the same way. If you use fidaxomicin, you can reuse fidaxomicin. If you use vanco, you can do that, or you can flip to the other one, doesn't matter. So it's the same recommendation. Once they've had that first recurrence and they come in for a second or third recurrence, Then the recommendation is going to be a vancomycin taper, which entails putting them on vancomycin for 1 to 2 months. So it's a long period of time, as you can see there, starting out with 125 milligrams every 8 hours for 10 days, followed by Q12 for 7 days, once a day for 7 days, every other day for 4 to 8 weeks. So you're looking at a significant. The other possibility, which we have done here, and actually works very well, is considering the fecal transplant. That really is only done for recurrences, multiple recurrences, in patients that are being hospitalized because of recurrent C. difficile infection. In the studies that have been published, the efficacy for fecal transplant is about 90% plus. So it's a very good efficacy. And the response rates that I've seen personally have been probably within 24 hours. It's an amazing recovery after you do the fecal transplant. Now, in the olden days, we used to have to harvest the stool from family members and do a lot of different studies. Nowadays, there's actually a company in Boston that has stool that we can buy. That's clean and clear and doesn't have any organisms. So there's a company in Boston, and that's actually what we use here. Is a company in Boston that has and developed stool that is free of, and the reason that I am saying that is because it would not be uncommon to have an organism. So these patients have to be tested for hepatitis and other things if they were donating their stool. With this one, we don't have to worry about transferring any type of infectious disease into a patient that is already significant. So severe C. difficile infection, and these are the definitions for severe C. difficile. At least 2 of the following: above the age of 60, temperature of 38.5, albumin less than 2, white count 15,000, frequently with severe C. difficile. It's in the 40 or 50,000 range. It's a huge leukemoid reaction, if you will. Admitted to the ICU because of C. difficile infection. And a lot of times with C. difficile, you may actually have microperforations from the pseudomembranous bacteria and the enlarged colon. And a serum creatinine increase from baseline of 50% or more due to dehydration because of the severe diarrhea. In this setting, PO vancomycin or fidaxomicin is recommended in combination with parenteral metronidazole. So the parenteral metronidazole is more systemic to get into the bowel wall versus the vanco and fidaxomicin, which is working on the lumen. So these are the recommendations now for any patient that has to go specifically into the intensive care unit because of the C. difficile. On occasions, patients will have the toxic megacolon. In that setting, besides the IV flagyl and the vancomycin, we actually will give vancomycin enemas to these individuals. So this last statement is important to say. So if your patient is on extended antimicrobials and they develop C. diff, the current recommendation is to continue C. diff treatment for at least 7 days after you've stopped the antibiotic. Why? The reason for that is because the relapse rates are almost 100% in patients. So if you stop the C. diff treatment before you stop the agent that's producing the C. diff, patients will have recurrences. It's almost 100% recurrence rate. So recommendation is at least 7 days after you stop the antimicrobial therapy, you're going to continue whatever C. diff treatment the patient is on. A little bit on multi-drug resistant gram-negatives, or MDROs. So the scope of the problem, this is just to give you an idea of the increasing resistance in the US and globally. And what we see here is the resistant infections have more than doubled in the United States from 2000. This cuts off at 2014, 2015. If we don't do anything about the multi-drug resistant, it is estimated by 2050, more than 10 million deaths per year, including more than 300,000 per year in North America because of multi-drug resistant organisms. Overall GDP loss of $60 to $100 trillion with 300 million premature deaths. So the added cost of treating a resistant versus a susceptible or sensitive infection is about $2 billion annually. So it's a significant amount, and this is probably an underestimation of about $1,400 per individual. So you can see more than anything is the high morbidity, high mortality with any of these individuals. So much so that actually the CDC and WHO have identified these organisms as top priorities. So the CDC is on the left and WHO recommendations on the right for infection threats. So threat level, urgent is for carbapenemase-resistant Enterobacteriaceae. We'll touch on that in a second. And serious for ESBL, or extended spectrum beta-lactamase producing Enterobacteriaceae. Multi-drug resistant Acinetobacter, which truthfully is probably the organism that I fear the most because it has the most resistance to the most antibiotics intrinsically of any type of gram-negative organism. And then after that, the multi-drug resistant Pseudomonas aeruginosa. It is important to note the escape pathogens down at the bottom. These are the ones that have developed resistance over the past 2 decades. Enterococcus faecium becoming resistant to vancomycin, Staph aureus becoming resistant not only to methicillin, but we now have what are called Visa or vanco-intermediate Staph aureus, and we've even had a couple of Versa vanco-resistant Staph aureus infections. Followed by the gram-negatives, Klebsiella pneumonia, number 1, which was really the leader of carbapenemase-resistant Enterobacteriaceae, followed by, as I mentioned, Acinetobacter baumannii, Pseudomonas aeruginosa, obviously, and Enterobacter species. So these are the ones that have these inducible gram-negative beta-lactamases. So these are the resistance patterns that we have, and what I put here is the U.S. in comparison with Georgia. All hospital-acquired infections, carbapenemase-resistant Enterobacteriaceae, you can see 3.5%. We're basically about the same as the national average of 3.5%. Skin soft tissue is about the same, CODIs are about the same, and CLAPSIs a little bit higher, but pretty much about the same. Multi-drug resistant organisms, Klebsiella specifically, in that setting, all hospital-acquired infections, 14.1, Georgia's at 14.1. Where's the biggest problem with MDR and Klebsiella? CLAPSIs. So at almost 24% of our Klebsiellas are multi-drug resistant. The same holds true for extended spectrum cephalosporins. And our biggest fear is this is really our last line of defense before we go into the broader spectrum antibiotics, carbapenems, meaning ertapenem and meropenem, where across the United States, there's about a 9% rate of carbapenem-resistant Enterobacteriaceae. In Georgia, about the same at 7.1%, bloodstream infections at 13%. The other one that most people pay attention to is E. coli, I mentioned, which is our most common bug that we have, fluoroquinolones. All fluoroquinolones, hospital-acquired infections, 33% of E. coli resistant to fluoroquinolones. In Georgia, as you can see, all hospital-acquired, about the same at 35%. So 35% here in this, excuse me, in this setting, followed by skin soft tissue at 35%. CODIs 35, and then CLAPSIs at about 30%. Fortunately, the carbapenems still have pretty good efficacy against E. coli, but it's not something that we normally would want to use, right? Ertapenem or meropenem for an E. coli type of infection. So I think the biggest take home here for you is E. coli is your most common organism. Beware that about a third of E. coli are resistant to fluoroquinolones, whether it's ciprofloxacin or levofloxacin. You do have to be careful with that one across. We do have a couple of new antibiotics that are being released or have been released, and I'm going to touch on these in a second. Let me see if I have that. So I'm going to go to this one instead. One of the newer ones that we have, ceftolozane tazobactam, which was approved 2 years ago. We have it on formulary. We rarely use it, but the drug, this is a combination of a newer cephalosporin with the same tazobactam, right, that is hooked onto piperacillin. So a cephalosporin with a beta-lactamase inhibitor, indications for intra-abdominal infections and complicated urinary tract, including pyelo. It does have activity against ESBLs, and it does have activity against Pseudomonas, including those that have ESBLs in that setting. Ceftazidime avibactam is actually our workhorse here for carbapenemase-resistant Enterobacteriaceae. You do need an ID approval for this. This is another one. So this is a third generation ceftazidime with avibactam. So avibactam is another beta-lactamase inhibitor. The difference between avibactam and tazobactam is that this is a non-beta-lactam beta-lactamase inhibitor, and it's not a suicide enzyme. So tazobactam hooks onto the beta-lactamase, and it destroys the beta-lactamase and basically destroys the tazobactam. The avibactam hooks onto the beta-lactamase, and it actually, once it destroys the beta-lactamase, it continues to function and finds another beta-lactamase. So you have a lot of this beta-lactamase inhibitor in the milieu, if you will, the infection. This has been approved for 3 indications: intra-abdominal, with metronidazole, urinary tract pyelo, and HAP and VAP. So it is important that these 2 do not have anaerobic activity. So if you're going to use these where you think there's anaerobic, you're going to have to add metronidazole. One that was just approved this past year is a carbapenem, meropenem, in combination with another novel beta-lactamase inhibitor called vaporbactam. This has been approved for urinary tract infection, but this is really used for multi-drug resistant. These are all different types of beta-lactamases that are used. There have been some cases of seizure activity and altered mental status with this, using it at this dose, but very, very rare, but it's the most common side effect that's seen with meropenem vaporbactam. But it does have a lot of activity against a lot of these beta-lactamases. So these are all different types of beta-lactamases that we see with the gram negatives. 2 other new ones that we have available, this was just approved this past year, is everocycline. Obviously, you can tell this is a novel, and it's a synthetic tetracycline derivative. It's approved for intra-abdominal infections. Activity at this point in time, we know it's broad spectrum, very similar to doxycycline or tetracycline, but it also has activity against vancomycin-resistant enterococcus, and it has activity against Acinetobacter. So one of the areas where we probably would use it would be a patient that have an Acinetobacter infection or a vancomycin-resistant enterococcal infections that is not treatable with daptomycin, for instance. Possibilities: because of doxycycline, tooth discoloration, enamel hypoplasia, inhibition of bone growth possible if used in children or during pregnancy. So probably one that you may have to stay with. Plasmamycin is the newest one, just approved at the end of last year. It's a next generation, a 3rd generation aminoglycoside. So why do we need another aminoglycoside? It's approved for pyelonephritis and bacteremia with it, because this aminoglycoside, plasmamycin, actually has activity against a lot of the beta-lactamases. Whereas the gentamicin and tobramycin and amikacin are inactivated, this has activity against a lot of these beta-lactamases. So it's used primarily in one setting, for multi-drug resistant organisms, specifically in that setting. It does have nephrotoxicity, just like any of the aminoglycosides, so you do have to be careful. And as with the aminoglycosides, the possibility of neuromuscular blockade, that's rare, all right? But that's seen with any aminoglycoside. But the bottom line is it should be used for one setting, multi-drug resistant organisms, and basically that's about it. And with that one, I will end the presentation. I think we have a few minutes. We take questions. Is there a way to take questions here? Yes. Okay, well, thank you very much for inviting me. It's nice to be here. Hopefully a little bit of a look into antimicrobial stewardship, some of the newer antibiotics that we have available. If you have any questions, you can email me or discuss any of the patients, always with the ID team or with the antimicrobial stewardship team. And we're always available to answer your questions and hope you help you out. So with that one, I'll end the presentation and I can take questions if anybody has any questions.
I'll just say thanks, Dr. Vasquez. That was very thorough, and I think the entire department needed that, especially given the fact that this is, a common utilization of medication for us in a field where we use really just a handful of other meds. So thank you so much for this.
Thank you for inviting me. I'll come in anytime. So when you started speaking, it sounded like there was a voice from God coming from the roof here. I was looking up at the ceiling saying, God, are you talking to me? But I think it's just Rick. So, well, thank you very much. It's certainly a pleasure. Call if you need something, and have a great day.